Hi, my name is Manesh Patel. I'm from Duke, and I'm excited to have you join us as we think about multidisciplinary care for our patients with venous thromboembolism. I'm joined by two friends and colleagues. It's going to be an exciting few minutes as we go through a lot of things. I have Elaine Heilich joining us from Boston. Elaine, thanks for joining me.
Thank you.
And Renato Lopez, who works both at Duke and in Brazil, but one of our DCRI colleagues and a researcher and clinician who takes care of a lot of these patients too. Renato, thanks for joining us.
Thanks for having me, Manesh.
So these are common patients that we see with venous thromboembolism. And I guess, Elaine, the first thing, and we think about multidisciplinary approach, is just, are there times when you think your patient who has a VTE needs more of a workup? This is a very common question. There are patients that have certain medical conditions. Are there times when you think, I need more of a workup, I might need to consult somebody else to help me with this?
Well, Manesh, I think the most important factor initially when you see the patient is, was this a provoked clot or was this not? And I think that really drives care. So is there an oral contraceptive pill? Was there lengthy airplane travel? Was there prolonged immobility? Was there a recent hospitalization? Remember that many of the DVTs in the community occur within 6 weeks of a hospitalization. So I think all of those are really critically important. Because then I know, am I going to be treating this patient for 3 months, or am I going to have to, get additional input from a hematologist about, potentially almost lifelong treatment for these patients? Inquire if there's a family history. Regarding cancer, we're all worried about cancer, but there certainly have been studies that patients should be up to date on their cancer screening for that older population. You don't really go out and do, CAT scans of, everyone if there's a clot. The most important thing, and this has been shown in randomized trials, is that patients should be up to date on their cancer screening, and that would really be the best thing to do for these patients. A common question for us at BU is always, should we be doing this big hypercoagulability workup? And I think most of the experts and guidelines say that no, that's really not necessary. However, you might be thinking of doing that for, women who are in that age group, may have had miscarriages. I think, younger women probably warrant a workup for antiphospholipid syndrome. But, remember that these clots increase with age, and age is a very powerful risk factor, as is family history.
That's really helpful, Elaine. Renato, some of the times when we talk to hematology or pharmacy colleagues is when cancer is actually present and we have cancer-associated VTE. Help me a little bit about, the evidence, or how comfortable should we feel about patients who have cancer and using DOACs instead of warfarin, and how long?
Well, that's a great question, Manesh, because as you know, when we proved that DOACs really came across and streamlined the treatment for VTE, the key question that all the scientific community and us physicians also were asking was, how about a pro-thrombotic status like cancer? Would DOACs really work in that scenario? And we didn't have a lot of data about DOACs. We had a lot of good data showing that in this particular setting, the standard of care is not warfarin. The standard of care is actually low molecular weight heparin. And so we needed really to have some data and some trials done comparing DOACs with low molecular weight heparin. And we've done those trials. And basically, I think that if we could summarize, we don't have a lot of time to go over the details, is that, yes, DOACs are at least as effective. Particularly some of the DOACs, not all of them were tested. So we had data with rivaroxaban, we have data with edoxaban, and we have data with apixaban, that those agents, the factor Xa inhibitors, are at least as effective as low molecular weight heparin, if not more, in preventing recurrent VTE in the cancer setting. There was one drawback, which was an increase in GI bleeding compared to low molecular weight heparin that we've seen mainly with Riva and with edoxaban. This was not seen in the Caravaggio trial with apixaban, which is very consistent with what we've seen also with apixaban in the AFib scenario, not increasing the risk of GI bleeding. But in summary, I think the good news that yes, we feel comfortable now in using DOACs for treating patients with VTE. They are associated with cancer. And we need to be careful about bleeding, because depending on the NOAC that you're going to use and depending on the type of cancer, particularly GI tract, we might consider using long molecular weight heparin, since we had less GI bleeding overall comparing to NOACs as a class.
Thanks, Renato. That's really helpful, because what we've learned, at least Elaine highlighted, we don't have to do a lot of workup in many of these patients. Maybe some of the younger ones, or the ones that are sort of hanging out, or let's say have markers of underlying other issues. Hematology might help us, or we might think about it. For our cancer patients, as you've just highlighted, there's great evidence we should feel comfortable. Elaine, maybe I'll come to you for the final question about some of our multidisciplinary. So we've talked about general medicine, cardiologists, hematologists, but how about pharmacy colleagues and our nurse practitioners? Many of them help us take care of a lot of our patients with anticoagulation. How do you engage with your pharmacy colleagues at BU, or how do you think about how you use them to work with OAC patients?
So, I mean, when you think about the transition from that initial period of apixaban twice a day and the rivaroxaban dosing twice a day that has to switch at 21 days, and the apixaban dose that you use through 7 days, it's critical to have some type of a pathway. We very much engage our pharmacy colleagues. Any patient that is certainly on the inpatient setting, we make sure that the patients understand that they need to do this dose switch on day 8 or day 22. Blister packs often are used to make sure that there's absolutely no way that the patient might take the incorrect dose. But a multidisciplinary team, I think, is critical to make sure the insurance coverage is in place, and to make sure that everyone is on the same page, including the patient and the family and the nurses. So we very much endorse a multidisciplinary team.
Yeah,
Well,
Manesh,
thank you.
and just to add, Manesh, sorry for that, but just to add, I think Elaine touched on a very important point about the dosing of the treatment for VTE is not necessarily the dose that we use for atrial fibrillation, which is the standard dose that we are very familiar with. There are different schemes. There are different initial phase, 1 week, 3 weeks for different doses and different NOACs. There are also the need for use, at least for a certain period of time, parenteral heparin for some of the NOACs like edoxaban and dabigatran. With rivaroxaban and apixaban, we don't need this initial phase with parenteral heparin. So there are differences and between the way we give these drugs, the dose we give, and in a way that having this effort being coordinated, I think is very important.
Yeah, thanks. I think both of you kind of hit the nail on the head. It takes a team, and the team has to be broad, from disease specific, but then also getting the therapy, getting the right dose, and making sure the patient gets it. So thank you both for joining me on this conversation around the multidisciplinary approach to working up and managing our VTE patients.
Thank you.
Thanks.